We're going to go ahead and get started. Welcome, everyone. I wanted to welcome everyone to the webinar. I am your host and moderator, Lauren Levine. We got a great turnout. It's probably because we got such an amazing speaker. We had close to 600 people registered. I always start my webinars off saying I hope that everyone is staying healthy and safe out there, and I commend all of you for being here this evening and continuing your dental education. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Elliott can speak for as long as she needs. She also wanted to leave time at the end for questions. Now, most of you have been on these webinars in the past. You know the format. We can't do verbal questions when we have 600 people on. On your screen, you have a GoToWebinar control panel where you can just type in your questions. I never know how many questions we're going to get. Sometimes we get 3, sometimes we get 103. We do obviously want to be respectful of Dr. Elliott's time, of all of your time. I may end up combining some questions together. I'm the only one that can see the questions, but the goal is to make sure that we get as many questions answered at the end. In the next few days, look for a couple of things. First off, as always, I'm recording the webinar. So if for some reason you can't stay to the end or you get distracted, don't worry about it. That recording usually goes out within a couple of days. As always, I want to thank GoldenDent for sponsoring the webinar. They're the ones that bring in these excellent speakers and help to develop what the content's going to be. They also handle the CE. After most webinars, I usually get a slew of emails asking about the CE. I'm going to try to mention it at least a few times this evening. Basically, there's nothing that you need to do. If you logged in with the link that was sent to your email, then that records you as entering the webinar, and when you log out, it will show us when you left. And as long as you were here for the bulk of the webinar, usually 45 minutes or so, for the content, not for the Q&A session, obviously, that they will then send out a CE certificate to you. When we have this many people on, that can take a week or so. They're usually pretty good about getting it out within 2 or 3 days. If you don't have it by this time next week, by all means, feel free to reach out to me and I'll follow up with Kurt to help you get that. So it's not too often that I get to introduce someone who is really a true friend of mine. I met Erin Elliott at a Greater New York dental meeting probably, I don't know, like 12, 13 years ago. We were part of the same business development group, traveled within that group to Beijing a number of years ago. I met her and Tom, her husband. She is a native Southern California resident, but she crossed the country to attend a small NAI school near Buffalo, New York. Go Bills, which is my team. So I'm glad to hear that she's a fan as well. She played collegiate soccer and graduated summa cum laude. After graduating from Creighton Dental School in the top 5 of her class, she settled in Coeur d'Alene, Idaho, and there she began her journey in dentistry at Post Falls Family Dental, which is also in Idaho. She loves to help people get great sleep, but don't worry, she's not going to be putting you to sleep today. I've heard her lecture a few times in the past. She is excellent. She has lectured extensively on sleep dentistry and technology and loves to help general dentists extend this life-saving service to their patients. She's an active member of the local ADA and the American Academy of Dental Sleep Medicine. She teaches a super engaging 2-day sleep apnea implementation course with 3D dentists and Dr. Tarun Agrawal. I also wanted to throw out there, she's not a particularly good pickleball player. And I know this as a fact because she actually built a pickleball court at her home, which you can do in Idaho because it's like $1 an acre for land. We can't do that here in Southern California, but I can still beat her, and I'm old enough to be her dad. So, Erin, we are thrilled to have you here tonight and looking forward to the presentation.
What a great intro. Well, thanks, Lauren. As you have heard, that I am from Idaho, and it is quite different than where I grew up in California. I'm not even going to tell you, Lauren, how much I paid for my 5 acres in Idaho. Just a quick geography lesson. I'm way up at the northern part of Idaho, just the tip, but I do not live in Iowa, so those are totally different states. I love being a potato girl, but I started almost 22 years exactly at Post Falls Family Dental, where I am now, and I have been the owner for, goodness, a lot of years now. I was an associate for 8 years. I discovered that dentists could be a part of sleep apnea in 2008. And as soon as I discovered that, I wanted to learn everything I could about it. You know, I was doing dental school dentistry and knew that as I progressed through my career that I was going to want to do more, be more, not get bored. But one thing I love to do is sleep. And so I was one of the first people in town doing it and continue to be one of the only ones. And Sleep Better Northwest was kind of not a separate business, but a separate brand, I guess, because I was getting referrals, but patients didn't want to, they thought they had to come to me as their dentist. So Sleep Better Northwest gave patients the freedom to come to me for this specialty and keep the dentist they love. And I was so proud of my tagline, stop snoring, start living. So clever, right? Except I realized there was a whole subset of people that we were doing so much more than just treating snoring. And so now, better sleep, better life. I mean, there's so many other taglines I could have used. But it also did a couple things for me too that I didn't realize. And one of them is put the patient in the mindset of medical. Because this is a dental solution to a medical problem, medical insurance is what covers it. In addition, when you go to your physician, how much time do you spend with the actual physician? Or are you spending time with the mid-level provider, a nurse, or medical assistant? So in this case, sleep apnea is a very team-oriented program within our practice. Yes, I'm a part of it, but really only at the beginning. My assistant can deliver, do follow-ups, adjustments, all of those things, and we kind of have a really good workflow that we've been using and get to help a lot of people that would otherwise go unhelped. So Post Falls, Idaho has this huge population of 33,000. The county is at 157, but we did have a huge influx during COVID, and we're really upset about it, have exploded to 188,000. But the reason why I say this is because one, we're closed is one reason I say it. But two, it has really elevated our practice in what we can offer and provide as far as implants and surgeries and cosmetics and all of those things. But no matter where you're at in the country, people have sleep apnea. No matter what happens in the economy, people want to sleep better. So we built this practice in 2007. I feel very blessed to be here. Nice Northwest homey feel. The guy in the middle has been my partner and boss for the last 22 years. And starting June 1st, he's going to be me and Dr. Kelly Harness's associate. So Dr. Kelly will be my partner. And how cool is it to have another tall blonde? Because no one can tell us apart. My patients think that I'm there all the time. It's wonderful. Again, have a big team that's really oriented towards the team doing as much as they can. So I just wanted to show you what talent I have as a general dentist as well. I kind of do all the surgery stuff and implants, and Dr. Harness does the cosmetics, but I just wanted to show you I got this tooth out, so I knew you'd be impressed with me, so I needed to share that with you. I'm going to have notes available for you if you'd like, and some blow-ups of some of the graphics I know you guys will like. So if you scan this QR code, I will have it again at the end. I will send you an email tonight with a link to a Dropbox that has all of that all the goodies in there. So I'll give you just another moment here. But the purpose of tonight is to give you an overview. Obviously, I can't teach you every ins and outs of dental sleep medicine, but there are a lot of ways to treat sleep, and dentists are really good at making things complicated. I'm going to share with you why it's important to screen. Most importantly, if you don't want to bill medical, if you don't want to build an appliance, you have to be talking to your patients because there's so many people suffering. And we're saturated with dentists, like I'm sure many of you are, but this certainly sets us apart because not everyone does it. Sleep is everywhere now. It's in our dental dental journals. It's in our policies that we should be screening. We know people that struggle with sleep, and maybe yourself, you struggle with sleep. I know it's a common problem because this is some of the best real estate at Rite Aid, and people are looking for the easy button. People are looking for a solution to better sleep, but they just don't know, one, why it's occurring, or two, what to do about it. So these are like the easy button pills when really they could be covering something much deeper. And we like to get to the root cause. So once you do treat a patient, they love to tell, everyone loves to tell everyone about it. So I've grown organically just by treating my own patients. And now I get a lot just from outside our four walls. But how many of your patients wear sleep trackers? How many of you wear sleep trackers? I mean, it's just so much more common to have patients that are aware that sleep is important to the total body wellness. Again, you could have poor sleep, but if there's nothing in the morning on the Fitbit that says you had poor sleep. Call Dr. Erin Elliott, which I think would be a great marketing thing if these companies ever got onto it. But again, patients are looking for sound, or if they have poor sleep, they don't know what to do about it, so they go spend $8,000 on a mattress and a cooling mat and all these things. It's a multi-billion dollar industry, when all they really need, the most natural thing, is oxygen and airway. So then their body's not battling and they can get into deep, restful sleep. Dr. Dement is the OG. He's the one that discovered REM in the 1950s. He started the first sleep lab. But even he, as a sleep physician, states that dentists need to be part of this solution. Unfortunately, a lot of the sleep physicians don't work with dentists, but we are staring at airways all day long. And when I first started, this is kind of the workflow that they wanted us to do and continue to kind of force down our throats. But I'm going to share with you what we do, because this is old, archaic, clunky. You see these signs and symptoms in a patient, and then say, talk to your primary care doctor. Well, the primary care doctor says, oh, look at you, there's no way you have sleep apnea, and does nothing about it, if the patient even brings it up. So then I started referring straight to the sleep physician, and it took a while to get in. Then it took a while to get the sleep test. Then they were calling here for the sleep results, but really they needed to be calling the sleep lab. And if they would get a phone call that says, yeah, you have it, now go get your CPAP, and then you'd wait around for a CPAP, which there was recently a huge shortage of. And then you wear it for 3 months when you didn't even want one to begin with, and turn it in, and they just kind of shrug at you and say, I don't know what you're going to do now. Just don't try that appliance. And then you hope that they come back. That's if they even continued on this journey. So I was very frustrated because there was a lot of patients that weren't getting help or didn't follow through. So what's better than just making it easy? So at that hygiene appointment, or getting a medical referral, we will bring them in for a consult and exam. Some come teed up with a sleep test, but getting that sleep test is, I think, the most important part. It's magical when patients see what is exactly going on and why they feel the way they do. I had a family friend who I've known him 20 years, finally came in. I'm growing old with my friends. They've known me a long time and they're finally coming in. But he really thought it was just snoring, that he didn't have sleep apnea at all. And after I went over the sleep study, he's like, wow, I came in here just for snoring, but now I realize how important this is for my health. And so we have a variety of ways, which I'll go over, to get a home sleep test, to make it easy so that they don't have to chase this down and wait and cost lots of money. So we will, I'll go over that later, what workflows we have for sleep tests. Then we bring them back for the review of the sleep study. I will only do that in person because I think it's that powerful. The financial arrangements, records, cone beam scan, and then of course we're getting a pre-auth and a referral in the background of everything we need to bill medical. You do not need to bill medical to be successful. Let me say that again. You do not need to bill medical to help your patients. However, you will just do a lot more if you unlock that mystical medical billing. It is possible. Probably 95% of what we do is medical billing. Then after we deliver, we let them get used to it, advance it as they can, get to a point where their jaw is comfortable and they're not snoring, or they're sleeping better, waking up more refreshed, and then do a follow-up test with the appliance in place. And then we see them annually after that. But I hear all the reasons why sleep doesn't work, all the reasons why dentists don't want to include this. And I know medical insurance is number one. We sell, I use that word in air quotes, we sell clear aligner cases all the time. So I don't know what it is in the consumer or patient mind that makes them not move forward or take control of their health unless medical insurance is billed. Like I said, you'll get a lot more yeses. However, you can still treat. Where to get education without someone selling you something, that would be where my course comes in. And then my biggest culprit of implementing anything new is not taking the time to do so. It's like I get all this knowledge, and then we get so busy doing buccal pits and crowns and class 2 composites that we don't even like doing, and that we forget to make the time for these important things that we can provide for our patients. As far as side effects go, I'll kind of have a little chat about that. And then sometimes the patient says no, and that's okay. I can see that they have an issue. Their airway is super clogged and floppy and red, and they breathe through their mouth and have high blood pressure and diabetes and all the things, and they deny having a problem. And that's okay. You're not going to win them all, but at least I can plant a seed. One thing I learned early on in my career as a dentist is I'm not going to care more than the patient. I can only give them the information I have. And basically what I say, if you are looking for verbiage, is I can see that at this time you're not concerned. I just want you to know I am. But when there ever is a point that it does start to bother you, we're here for you. So there's kind of their opening to, come back to us if there ever is a pain point for them. And then of course, change is hard. Teams sometimes rebel, but in our case, every team member gets a sleep study, every bed partner gets a sleep study. And so they can understand what's going on and what we do. And most of them are treated and have their own personal story. But with Phyllis, she came into me early on in my career before I found out about sleep apnea. And she came to me because she had a food trap. She did not come to me because her bite was shifted. And as most patients do, I'm like, go ahead and bite down. And she's like, I am. And then I said, no, bite on your back teeth. And she's like, I am. So of course I grabbed her jaw and jabbed it back. And I'm like, come on, bite on your back teeth. But this was her bite. And I couldn't understand, I had occlusion with Dr. Wilcox at Creighton University, and I just knew that class 1 canine guidance could cure cancer. So I didn't know how Phyllis was walking around. So I kind of freaked out and tried to get to the bottom of it, and it was discovered that someone had made her a snore guard. And when I hear snore guard, to me that means we just gave you an appliance and sent you on your way. There was no exercises, there was no AM aligner, and there was no sleep study. It's like, here you go, I read about this thing in an ad, so let's just take a couple of impressions and give you this. And there is a lot more to it than that. But she wasn't given any instructions or stretches or anything. And so I sent her to the orthodontist, bite change due to sleep apnea device. But what was the craziest thing to me and what really changed my mind and changed my thinking is that the orthodontist sent back this thing that said no orthodontic treatment recommended at this time. And I couldn't understand it, but then I realized it's because Phyllis did not want to be treated. She didn't even know she had a bite change, and she said, "You will not take this out of my hands. I have never felt better, and I don't care if my bite changed." Her bite wasn't perfect to begin with. You can see the crowding that she had. And so I realized at that moment that sleep and oxygen is way more important. Now, I am not promoting bite changes. I do inform the patient beforehand that it could happen. I also, we try to prevent it with an AM aligner that has their original bite, as well as exercises and stretches. But I kind of get in front of it that if it does happen, it's usually because the muscles are relaxed. There's no pain with it. And you could always recapture the bite if they go to CPAP and stop wearing the appliance. For the most part, if there is a bite change, it is small. No one looks like a bulldog and no one misses a meal. And so it's just been a handful of people that have needed to move to CPAP because the bite change was enough that we needed to abandon treatment. But for the most part, it doesn't happen very often. And if it does, it's not a very big deal. So this is an old study, 2013. So I bet we even have better numbers than this. But essentially, 17.9% of the time. However, only 28.6% of patients even noticed that there was a bite change. Mandibular advancement device at the beginning of that conclusion may lead to the development of TMD in a small number of patients. Nevertheless, sorry, my panel's in the way. These signs are more likely transient. Patients with pre-existing signs and symptoms do not experience significant exacerbation. So if the patient has a joint issue, then an acute joint issue, then we get that under control first. I basically have them point to where it hurts. And if they point to the joint, then I send them to a TMD specialist. But if it's muscle, a lot of times it's because they're clenching or grinding due to the sleep apnea. So with treatment, it actually gets better. Now, step number one in anything you do is to find your why, because you're going to come up against some obstacles. You're going to have some people that say no. You might get a medical insurance denial and throw up your hands and say, see, this doesn't work. But if you have those wins in the back of your mind, if you have your why, then you won't give up. I have patients that tear up and she's like, you've changed our lives. I got my husband back. I thought he's the 33-year-old man who comes home and falls asleep on the couch, and I thought that was our future. And I've come to terms with it. But now he's got, new lease on life, lost 40 pounds, plays with the kid, all those things. And so I teared up too. I'm like, and this is why we put up with what we do with the medical insurance. I'm always reminded when I get frustrated, I'm always reminded why we do what we do. But to begin with, why I got interested is because
my name is Kathleen.
I have patients like this.
I decided to get checked for sleep apnea years ago when my sister died from sleep apnea. She fell asleep on the couch and she never woke up, and it was diagnosed that she had sleep apnea and it had enlarged her heart. So I decided to get checked, and I had been overweight. So I also worked on losing weight. I've lost 96 pounds. I've kept it off for 2 years now. I used the CPAP machine before I lost weight, and it worked pretty good. After I lost weight, it didn't work very well at all for me. I was referred to Dr. Elliott to have get fitted for the sleep appliance, which I have started using, and I can't say enough good things about it. I have already noticed an improvement just after a few weeks of using it. My husband says I'm not snoring anymore at night. I'm not waking up. I'm feeling rested, and I am just very happy that I have found this device, and I am extremely pleased with it.
So notice that she said her sister died from sleep apnea. I think that this would be more top of mind of physicians, of patients, of consumers, if the death certificate actually did say sleep apnea. Most of the time it says heart or stroke, all the other reasons, but at the root of it is sleep apnea. She lost weight. Usually losing weight doesn't cure the apnea, but reduces the severity. So that's a very typical story of CPAP really not working anymore and how the appliance can help with that. Then we have Nathan, and he's so much fun. Let me share his story.
I love coming to the dentist, and I have since I was a little kid. But when I got my mouth guard and did the sleep study, it literally changed my life and my wife's life, and probably my kids and coworkers and everyone else. So I cannot go a night without it. I travel everywhere I go. I take my mouth guard, and it literally has changed my life.
And he does. He travels all over the world, and so he couldn't imagine. He wouldn't be able to take his CPAP with him because he goes to places in like Africa and really remote places. He works with human traffic or nonprofit to end human trafficking. Then here's my way: is that I love to sleep, and I can sleep anywhere, anytime, any place. And my family is there to help capture it for me, and of course put it on Facebook. So saying that, I'm like, well, I have a lot of ugly photos out there. I've got to find a way to get some pretty ones. So my husband and I love pranking each other, so I don't mind that he does this. But oh, that one's really bad. I decided I could get him back. And that is by putting pretty photos of me and even a photo of him sleeping, and it was a lot of fun. He definitely got some attention there. So when we talk about, I love to try to simplify things and make it as easy as possible and step by step as possible. So when you break down the dental sleep medicine workflow, and I'm speaking towards appliances, not going into like expansion and myofunctional therapy and tongue tie releases and all of those things. Yes, that can certainly help people as well, but I like to start simple, get the patient feeling better, get the patient even acknowledge that they might have an issue, and the sleep study brings ownership and value. And then if they're wearing an appliance and they're like, hey, I love how I feel, is there a way to make this permanent? Then we can go down all these other trails. You got to start simple, conservative, and low cost a lot of times. So in creating awareness, that's mostly done in hygiene. And that's why it's important to have your team on board, tested and treated. Then we get the patient to a diagnosis. Again, that's a magical place when we can go over those sleep study results. And then the financials, and then finally treatment. And oftentimes dentists love to skip to the treatment part, like what appliance do you use? And I'll kind of go over some options, but it really doesn't matter what appliance you use if you don't have a patient to put it in. You got to learn how to talk to patients and which patients that you kind of choose. So why do we care? So sleep-related breathing disorders are kind of on a continuum. Oftentimes it starts as snoring. I'm going to go over in detail upper airway resistance syndrome, and then obstructive sleep apnea is what we treat. Central sleep apnea we cannot treat with an appliance. However, it is rare to have a majority of central sleep apneas. Central sleep apnea is where the brain does not tell the body to breathe. So snoring is where I focused on at the start. And it's not a bad place to start because it affects a lot of people. They say 40% of the population snores, but when you ask the bed partner, that number rises to 59%. 35% of married couples are no longer sleeping in the same bedroom, and oftentimes it's because of snoring. Or I don't even know the number of wives that have to wear earplugs. Or I have so many men that come in here because they're on the couch now. But what snoring is narrowing of the airway and vibration of soft tissue. So in its purest definition, primary snoring means the patient's been tested and all they do is snore. They don't have any arousals. So what an arousal is an interruption of sleep. It's an increase in brainwave activity. So essentially, you're going from a deeper stage to a lighter stage of sleep. Now, in primary snorers, they just snore. They just make noise. They don't have sleep interruptions. But I will tell you what, this is maybe 2% of snorers. Does anyone need to have to sleep next to something like this? I don't know if that's coming through real loud, but this was recorded in our bedroom. And that snoring is actually me. And like most of my patients, I denied it. And that's why there is video evidence that was posted on Facebook, because you're asleep, you don't know. And I will tell you, every snorer has never admitted to snoring. And so when I can talk to them about other pain points, like not waking up refreshed or falling asleep driving home, or their hypertension, then oftentimes they might get motivated. It's not always snoring unless their wife is bothered or bed partner is bothered by it. But what obstructive sleep apnea is an obstruction of the airway. Usually the soft palate and tongue collapse back and prevent the oxygen from reaching the vital organs and brain. So you can see here that this tongue, this is like a sleep MRI, so it's in real time, obstructive sleep apnea. Most people don't realize how large the tongue really is, but of course we as dentists know. So I'm going to have you guys do this exercise just so you can understand. So when you breathe in, or when an apnea occurs, it's usually on the out breath. So I'm going to have you breathe in, breathe out, and hold. So go ahead and breathe in, breathe out, and hold. Okay, breathe. Now, how did that feel? So what you just did was you were the bare minimum of what an apneic event is. So in its definition, found on a sleep study, an apnea is a complete closure of the airway. It means without air or without breath. So a complete closure of the airway for 10 seconds or more, and a 3 or 4% drop in oxygen. So not only does your airway have to close for 10 seconds, which you guys just experienced, but your oxygen has to drop 3 or 4%. Now I want you to remember the feeling that you had at just 10 seconds. Did your heart start to beat a little bit faster? Or maybe a little panicky of like, this is the longest 10 seconds ever? Now, if you had a pulse ox on at the same time, your oxygen probably didn't drop a full 3 percentage points. And so, like I said, I want you to keep that in mind, because when we look at a sleep test, I like to look beyond just the apneas and see if there are arousals or sleep interrupters or airway closures that just weren't bad enough to qualify. So apnea, again, 10 seconds or more, and a 3 or 4% drop in oxygen. Kind of looks like this.
Wait a second now. Oh, there it goes. stops breathing. Trying to. That's what. Trying to breathe, can't do it. Trying to breathe, can't do it. Nope, still not breathing. Trying to breathe. Trying to breathe. Oh, a little bit. There we go.
So he has some pretty good friends there. But the big thing there to see it, witness it, is that he's trying to breathe, but the airway is closed. In addition, he brings his lower jaw forward when he kind of starts breathing again. So that just shows you that bringing your lower jaw forward opens up the airway. And I see it a lot in my sedation patients as well. Like I can see apneas occurring in real time. It's a great way to screen patients actually. But then there's something called hypopneas. Hypo means less than. Hypopnea, not hypoxia, but hypopnea means that you have a partial closure. So it means less air. You're getting some air, but just not a lot, that your oxygen goes down 3 or 4%. So a hypopnea is counted in a sleep study as well. So I kind of explain it to patients like you are breathing through a straw instead of a nice wide open airway, like this. You can see his eyes working hard. He's not in that deep, restful sleep. Technically, there's still some air getting through. Those red, rosy cheeks are more oxygen deprivation than sunburn. Hard to watch, right? And this is kind of how I think of the airway. Snoring shows that there's resistance or turbulence. Hypopnea, there's a trickle of air, and then apnea is a complete closure. So what I mean by DSAT of 3 or 4%, that has to happen. If your airway closes down for 20 seconds, that's not going to feel great, but your oxygen only goes down 2%. They're going to say, oh, no, no big deal. That doesn't count. So the general definition is that the oxygen has to drop 3%. Well, Medicare came along and said, no, your oxygen has to drop 4%. You need to be sicker in order to qualify. So a lot of the major carriers said, yeah, we'll just do what Medicare does. And so that's why on the medical policies, we know who is 3 or 4%. And on a sleep study, we will change it accordingly. But you can see what a bad cycle this would create. As we start to snore, the airway narrows, apnea occurs, the oxygen goes down, and the brain says, we need you to breathe. So it shoots out adrenaline or cortisol, the stress hormone, to open up the airway for breathing to resume, and then you relax and go to sleep. And it happens over and over again. So you never get into that deep, restful sleep. You never get into REM sleep. If you haven't remembered your dreams in a few years, that could be a sign. Now, on a sleep test, they give you what's called an AHI, which I think is a terrible way to measure people, because there's a lot of people that would show up normal according to this, but they're suffering. So anything, they basically count up all the apneas and hypopneas divided by the number of hours slept. So if you're under 5, you're considered normal. 5 to 14.9 is mild. 15 to 29.9 is moderate, and anything over 30 is considered severe. It's kind of an arbitrary scale that was defined 40 years ago, and it was never supposed to stay this way. So I like to treat the patient that's in front of me and their story, and not necessarily the numbers. I have to play the numbers game for insurance. But if a patient is sleeping like crap, has insomnia, and they show up normal, I'm not going to send them on their way, but there are a lot of doctors who would. So then they go on thinking that they're just crazy, when really it is sleep disordered breathing that's the problem. It is their airway, but it's just not bad enough yet. So upper airway resistance syndrome patients are sometimes the most sick, the most affected, but they're told that they're fine, or it's not that. So what they have are a ton of arousals, those sleep interrupters. They don't always have snoring, but basically there's no oxygen desaturation because they're so young and healthy that their body's not going to let them desaturate. So these arousals lead to sleep fragmentation and disruption. And I wouldn't even say sleepiness, it's more exhaustion. It is common in young female TMD patients. And what they experience are what are called RERAs, or respiratory effort related arousals. So again, airway could close off for 20 seconds. And if the oxygen only desats 2%, they're told they're normal, but that's not, it's still going to have that cortisol reaction, the adrenal reaction. It's the brain has to go, oh, let's get breathing. Airway starts to close. Brain says, nope, we're not going to let that happen. Airway starts to close. Nope. So constantly fighting to keep the airway open and winning at the cost of good sleep. So they're usually the young, fit female, and that's because progesterone and estrogen help keep the airway open. And when you're young, you have better muscle tone. There is usually not weight that's an issue. So progesterone and estrogen are working really hard to keep the airway muscles open. It's the body's working really hard and fighting to keep the airway open. And one way to open the airway is clenching. So TMD patients is due to clenching. Most Bruxers are, their TMD is fine. Their joint is fine. They don't have any problems. So with that, all that extra fight or flight and sympathetic drive, they get in high sympathetic tone, which can lead to anxiety, exhaustion, and fatigue, not doziness or falling asleep. If someone says they're a light sleeper or wake up at 1 a.m. at 3 a.m., toss and turn, and have insomnia, I mean, this is just so typical of upper airway resistance syndrome or mild sleep apnea. And so that term mild is oftentimes a misnomer. It's someone is mild because their body's fighting like heck to make sure that happens. It's fighting hard to keep the airway open. So what I explain to patients is that even though it said you're mild, you're the most symptomatic. You're more symptomatic or know there's a problem more than a severe old fat man whose oxygen tanks into the 60s. They sleep right through it. So with an appliance, the airway will be held open for you, so then you can finally rest. You can stop fighting. You can get into deep sleep. And when I say 1 a.m. or 3 a.m., people lean in, their eyes get wide, like, are you in my bedroom? And that's because clenching is a way to keep the airway open. But in REM sleep or dream sleep, you can't clench. Our body is paralyzed, so we don't act out our dreams. And so if you're waking up at 1 a.m. and 3 a.m., that's the height of REM for most people. So it's interesting that it's so typical. And when I say these symptoms before they tell me, they're so amazed. And I had a woman tear up because she's like, I'm not crazy. It gives them reassurance that I've seen this before and we've helped people just like her. And what makes me crazy is how many people, if they didn't find us, would be turned away and told that they're normal, even though they're not. So they say it's, about 20% of the population that has sleep apnea, but I don't believe that's true. I think at my course, we do about 20 sleep tests, and it's over 50% usually that has sleep apnea or upper airway resistance symptoms. The incidence between men and women becomes equal at menopausal age. Because remember I said progesterone and estrogen help keep the airway open. And what happens to those hormones in menopause? And that's when insomnia symptoms start, because women present as insomnia. And that's why I had to get away from just focusing on snoring, because women with insomnia is sleep apnea or sleep disordered breathing until I'm proven wrong. So then they report insomnia to their doctors and they go, oh, welcome to the club. That's just menopause. And the problem is up to 80 to 90% of patients are undiagnosed. And of those ones that have been diagnosed, and went through all of that hassle, how many are actually using the one and only treatment option given to them, which is CPAP? It's about 60% if they even went and picked it up. So we have to be there for doctors. Begrudgingly, sleep physicians will refer. The younger sleep physicians do refer a lot because they've been trained, and the research shows that appliances work, and they tend to listen to their patients more. The older ones are they think they have 100% success with CPAPs and give one to everybody. So in creating awareness, what do we look for? We can tell based on their health history as well as their anatomy. So when it looks at health history, do you have any patients that have hypertension, AFib, congestive heart failure? Patients that take baby aspirin tell me they're trying to prevent a heart issue. And good sleep and not stressing the body out when it's supposed to be resting is a good way to help prevent a heart issue. So we can speak to that. Depression, anxiety is one of the most common prescriptions in this country. Snoring can create relationship discord, sometimes morning headaches, diabetes. Do any of your patients have that? Or trouble controlling their blood sugars, trouble losing weight. And I know that's easier nowadays. However, losing weight doesn't necessarily cure the apnea. There's still anatomical and physiological reasons. It's just going to reduce severity. Acid reflux, ED, and nocturia, which is frequent urination at night. And that's not necessarily my favorite one, but I like pointing this out because nocturia can be directly related to sleep apnea. So I will give someone in their older years one time a night to get up to use the restroom, but if it's any more than that, again, in my mind, it's sleep apnea until proven otherwise. If you've ever dreamed of drowning, that's sleep apnea until I'm proven otherwise. So far, I'm like 100%. But if you were to just even look at the top 4 conditions, these are so many of our patients that we could be talking to about asking about how they sleep, if they wake up refreshed, if anyone's ever told them they snore, have they ever considered that they might have something called sleep apnea. I don't always lead with sleep apnea because sometimes patients are real resistant and defensive. But here's a typical patient. Our paperwork says medicine, dosage frequency, and the reason why. So this patient has myocarditis for high blood pressure, metformin because he's pre-diabetic, baby aspirin for the heart, Protomax for acid reflux. And I know I mentioned it real casually, but ED is a thing. Not every patient tells us about it, but this patient did. So he goes on to say Viagra twice a month if he's lucky, but mostly just once a month. So sometimes the patients give us a little too much information, but this is very typical of the types of medications sleep apneics are on. And no one ever talked to him about sleep apnea. So we can look at health history, and we can change our health history. I ask, have you been told you snore, not do you snore anymore? So these are a good way to screen our patients. I don't really use screeners or questionnaires. I like to start a conversation. All the little check boxes at the bottom of the page, I've added these because that will start a conversation. Again, I have notes for you. I have that QR code at the end. Then we have subliminal messaging around the office, creating awareness. And whatever it is you want to do more of, make sure patients know you do it. So I have one message for women. I mean, doesn't she look tired and exhausted? And then I have another message for men. Trying to kind of cover all of the bases of the types of sleep apnea. And then as far as anatomical reasons for sleep apnea, bruxing is kind of at the top of the list, and scallop tongue is another big one. If someone bruxes or clenches, I actually, before we do a night guard, I will screen them with a sleep test. So I do promote owning sleep tests and distributing them. if anything, at least for making it easy for them to have like, okay, this is a problem, you know, I'll go get a real sleep study. Now, if you're worried, if you are in a state that doesn't allow, it's only New York and New Jersey. And so I pretty much encourage dentists to have sleep tests to make it easy for patients to get screened. Just like we have high blood pressure cuffs in our practice, we are not diagnosing hypertension. We are not prescribing medications for hypertension. We're using a tool to help screen for a silent but potentially deadly disease, which is exactly what a sleep test does for sleep apneics. So this is kind of the why behind bruxing and clenching and how it helps open the airway. So the top is an airway at rest. The middle is an airway that's closed off. You can see the tongue from the sagittal view. And then this is an airway in a clench. So I'm going to share this with you. I know I got to bring it home. I get so excited to tell people about upper airway resistance that I know we need to get to what appliance to use. But I want to share this fun video with you first.
Now this is a story all about how I can help you sleep without a sound. I'd like to take a minute, just sit right there. I'll tell you about how I became the queen of good air. In sunny California, born and raised, Post Falls is where I now spend my day. Chilling out, drilling, relaxing, all cool. Using Mr. Thirsty to suck up the drool. With a couple of scores, they were up to no good. Started making noise in my neighborhood. I said, let's fix that snore, but my team got scared. But to help sleep apnea, we have to get prepared. We scanned lots of teams day after day and knew we were finally on our way. If you're having trouble sleeping at night, waking up groggy in the morning light, causing your partner to complain about the noise, we can help your problems, have no fear. A simple appliance will make things clear. I looked at my practice, I was finally there to sit on my throne as the queen of good air.
How fun, right? Well, don't worry, I am not a one-hit wonder. You can look up my Air baby as well. So to get a patient to the diagnosis, a lot of patients think they need to go spend the night somewhere strange. They don't. Home sleep tests are used quite often. But what I'm going to recommend is to not just make a snore guard. Make sure that every appliance you make has a sleep study. So this is the in-lab where patients think they have to go when really they could do a home sleep test. So I can see why people wouldn't want this, especially with a recording watching you. But home sleep tests are way more common. So the way that we do it is we distribute our own, that we have some machines here, and we do it for a cash fee. We do not bill medical. Dentists cannot diagnose. So we have a sleep physician in the cloud that looks at all the squiggly lines and all the numbers and says, yes, this person has sleep apnea. We also, depending on the medical insurance policies, and you most likely will not start by billing medical. So if you're doing fee for service, you could do your own home sleep test, get a diagnosis from a sleep physician in the cloud. And for certain policies, we will use a third-party telemedicine. It's just, the wait list is so long around here locally, and there's a shortage all across the country that the telehealth has been so easy. We can get a patient tested and diagnosed within 2 to 3 weeks. They bill the patient's medical insurance. You don't have to pay for it. So it's really a beautiful thing. And I still sometimes refer locally, but they have to be really kind of complex patients. So I do utilize sleeptest.com. They take care of everything. A pulse ox is not a sleep study. That's just to show you, oftentimes people's oxygen doesn't go below 90, so they're told they're fine when they're not. This is just some pictures of Coeur d'Alene, Idaho. Remember, we're full. That's my front yard. This is my backyard. Okay, kind of fun. And then when it comes to the financials, I know it can be frustrating. These are all the things that we get in order to do a pre-auth. Every appliance I make has a MD, a DO, a nurse practitioner, or a PA signing off on it. It's not the same doctor usually as the one that does my diagnosing. Someone locally that this patient is in the care of. If you go to sleeptest.com, they will get you a referral for the appliance. And so no matter what, every appliance I make has a sleep study, diagnosed from a sleep physician, and a prescription for the appliance itself. So I am not practicing medicine, and there's no liability that way, like you're doing the right things. But like I said, we can somehow sell clear aligner therapy or clear aligner treatment for $5,000, but can't get a patient to say yes to $2,500. So I don't understand the psychology of it, because this could literally save their life. And so when we kind of talk about $2,500, we don't say for the appliance, because patients look at the appliance and go, that costs $2,500. Well, no, but all of the time and energy, you don't want to have to try to explain the cost of it. Do they ever look at the aligners and say those cost $5,000? No, they know that it's a means to get to the end, which is a straight smile. So again, we try to talk about the program. The therapy costs $2,500, and usually I do $500 down and then payments after that. That kind of covers costs and makes it affordable, because this same patient will go spend $8,000 on a mattress, but it's because it was 0% at $100 or whatever it is that they agreed upon. We have to start thinking consumer language or consumer thoughts. What does fit into your budget? How can we help you get the sleep that you need? And then finally, treatment. All sorts of options. I don't use, we have to be more than a one-hit wonder. So again, I know we go down so many rabbit holes with myofunctional and tongue tie release and mouth taping, and most everything can be used in combination. And so there is not just a one perfect solution for every patient. Inspire is pretty crazy. Basically, you implant a pacemaker, and then it plugs into the hypoglossal nerve. So if the tongue falls back, then the tongue gets zapped to come out of the airway, which is exactly what an appliance does. This surgery is very excellent, very successful, but getting a patient to go from, I don't think I really have a problem, to you must get double jaw surgery is kind of a tall order. So start conservative, start easy for something that works. So by bringing the lower jaw forward, you bring the muscles of the tongue with it, you support the hyoid bone, and you bring the constrictor muscles with it. So this is a video of a patient who was put to sleep, and then a camera was put down the airway. So I just want to show you just how effective at opening the airway is when you bring the lower jaw forward. And see how the airway's trying to close there, but it's splinted open. So when you open up the airway, you basically tighten the tissue so that snoring is just a benefit, a side benefit to an open airway. So I love the Kettenbach putty wash if we have to go analog, but more and more we're doing scans only. And we take a starting bite to give enough vertical for the appliance, and then kind of a starting position forward. I like to use the SOM gauge. There's expensive machines that could help you. I don't think a George gauge is enough. I think the SOM gauge is a great solution. So instead of the maximum intercuspation bite, you would take a bite with the gauge in and scan. And boom. So as far as appliances, I don't like the elastics that stretch out. The internet ones, of course, are not going to be great. They're bulky and don't give you freedom of movement. The Silent Night is cheap. It's the cheapest one and very commonly used. The problem is they break. And it's kind of like you get what you pay for. Anterior hook is common. They've been around forever, but in my mind, they cause the most TMD discomfort. So what we mostly use is a HERPS because some insurances and Medicare dictate that. But if I didn't have any parameters set by medical insurance, then this is kind of what we go to. I can just tell you it's ProSomnus. Evo, it has a little flex to it. It's milled from a puck. And so it's got the smallest footprint, but also strength. Another one that is great is the nylon 3D printed because these don't break and they are a great solution, last a long time. Everything I use has a 3-year warranty. So we use cone beam. I can find a lot of pathology. I also look at the nasal obstructions, but cone beam is not the best screener. Yes, you can see the airway, but just this person standing up and awake. And so it's not a good judge of is the airway small or not. So that was my other video, but kind of what can you do from here? Start talking to patients, just practice, talk to your team and get the verbiage down, the conversation started. You can change your health history. Have your team look for, you don't need to look at all of these things. Even if you were to look at the top 4 conditions, scalloped tongue, just a small swollen airway, and bruxing or clenching and acid reflux is a great place to start. And then we can identify who our candidate of the day is going to be before the patient even walks in based on their health history. Or did we make them a night guard before? And if we just look at these top 4 conditions, then that is a lot of our patients. And can we show them? Cone beam is a great conversation starter. Again, I didn't say it's a good screener, but it at least explains to patients why we as dentists care. So at the very least, I'd find a dentist to refer to or kind of get more training and help your patients live longer, but with also a better quality of life. So that brings us to the end, and you can get notes and blow-ups of those, the body as well as the Elliott evaluator and those types of things. And Lauren, gonna shoot it back over to you.
Well, I've been doing these webinars for about a dozen years, Erin. I don't think anyone's ever done a Fresh Prince rap video, so that was very impressive. The content was fantastic. You've added a lot of new stuff since I last heard you speak. So before we get to the Q&A, I'm going to mention that we don't have a ton of questions yet. This is your time. If you have any questions about the things that Dr. Elliott talked about or any questions, anything to do with sleep apnea, by all means, this is your chance to type it into that control box. As a reminder, I know some of you popped on a little bit late, so the webinar was recorded. That recording will go out usually within a couple of days. When you log in and log out, it also will let us know how long you were on for the webinar. And as long as you were on for most of it, you will be sent a CE certificate. That process, sometimes it takes 2 or 3 days. It can take up to a week or so. GoldenDent is going to send those out, so keep an eye on your inbox. If you don't have it by next week, let me know. Speaking of GoldenDent, it's always my pleasure to have them sponsor these webinars. One of the reasons I like working with them is that they'll bring in speakers who don't necessarily talk about things that GoldenDent does or sells. And this is a perfect example. I don't think there was anything that Dr. Elliott talked about that GoldenDent can get you. But that doesn't mean I didn't ask Kurt to come on and make some offers for everyone, because I know that a lot of you are clients of GoldenDent. So I'm going to present Kurt Lawler now, who's going to go over some of the specials they have for tonight, and then we'll get to the Q&A session. So Kurt, take it away.
By the way, I love GoldenDent and use a lot of their stuff.
Thanks, Erin. I appreciate it. This is Kurt from GoldenDent, Kurt Lawler, based here in Detroit, Michigan. And before I forget, Erin, you might want to just take a look at that QR code. I did get it myself at the beginning, and it said something like it was under construction or something. So you can send it to me if there's still an issue, and I can forward it to everybody.
Okay.
Anyway, so like I said, we're based here in Detroit, Michigan, and I know we get a lot of our customers join our webinars on a regular basis. Like Lauren mentioned, this wasn't specifically on a GoldenDent product or technique this evening, but we listened to our client base and they asked for different subjects, and this is one that has come up, and so we try to provide this as a courtesy for our customer base. So I hope you enjoyed the presentation. So I came up with a very creative promotional code, SLEEP 15. So that's a 15% discount. If you're looking to, like I said, to stock up on some regular products you're using, this code will work for you until tomorrow at the end of the day. So I just thought I would take 2 minutes here before we get to the questions and just mention sort of what's new at GoldenDent. If you haven't taken a look at our site recently or got one of our catalogs with your recent order, I just wanted to mention a couple products that we've been working on. So we're excited to have, we're about ready to launch our single-use diamonds. So there are a lot of diamonds out there in the market, but we did a lot of work around these. They're made here in the States, and we're excited to have this page live actually now, and we'll start to send some information shortly on it, but I just wanted to mention to kind of look out for this. We're going to be launching these single-use diamond burrs here pretty soon, and they are live on our site now, but we'll send more information soon through email if you subscribe to our page. So we have the X-Star Curing Light from Woodpecker. We're excited about this one too. So we're going to finally be shipping this in end of May, if we're lucky, maybe very early June. This is a excellent curing light. It's the best one they've made. We're really excited about this. We've been doing a lot of testing and having reviews done by different universities, and the feedback has been really excellent. So if you're ever looking for a curing light, keep this in mind. The Woodpecker X-Star has a lot of great improvements over the past versions of some of the curing lights they've made. So this, just quickly, we keep expanding our matrix, our portfolio. So we just picked up the Polydentia, which is a nice anterior system. Up in the top right corner there, we have our Quick Connect system, which is a really nice retainerless Tuffelmeyer type system. And then we have rings, nightie rings and plastic rings that maybe look familiar here, which have your V-shaped tines. So we have those also available. Lastly, this one, we've worked on this for a long time. So we've had the Vibroject. The Vibroject's been around forever. So if there's anybody that's a Vibroject user, the Trick Shot products, the new one that we just came out with, it had some improvements over the previous versions, and the Vibroject really hasn't changed in decades. So this is one product that we're just actually finishing right now, and we'll be shipping this one soon too. So if you're using a Vibroject and something happens to it, just remember we do have a new version of this. Lastly, I'll mention, just because Dr. Levine and his team are actually providing the support for our digital X-ray sensors. That's one of the battles with the sensors, is you want to make sure they're compatible with your practice software. And we've engaged Dr. Levine and his team at the Digital Dentist to help you with that. If you do purchase sensors through GoldenDent, that's a huge advantage, and to make sure that it's a smooth transition to get them to work with your practice software. Lastly, we have been doing these courses in Detroit. They're live patient programs. I just wanted to mention, if you're not familiar from the past, these are all live patient educational programs that focus on extractions, grafting, and then we do a classroom-based program on endo. Looks like we have a couple dates coming up here in May and June. If you're interested, there's amplifydental.com is our educational website. Lastly, I try to mention this too because we put all of our content on YouTube. We film pretty much on a weekly basis, whether it's product-based or clinical-based. It's a great place for just free clinical videos. All our past webinars are on there, and it's a good place to take a look and subscribe if you're not familiar with our YouTube channel. June 10th is our next one. Looks like we're doing dental emergencies with Dr. Matt Burton. I'll go ahead and send the invite if you want to join us again June 10th when we send the replay and the CE letter for the webinar this evening. That's it for me. I'll leave this up. Again, it's Sleep 15, and I appreciate everybody's time this evening, and I'll turn it back to Lauren to go over the questions. Thank you, everybody.
Thanks, Kurt. Appreciate it. Erin, you got time for a few questions?
Yeah, and I apologize, but that website is not working. It did not get fixed like I was told it was. So I put my email address up there. And so I will get you the stuff, but just remember I have 2 L's and 2 T's and 2 D's. So Erin Elliott DDS@gmail.com. If you put 1 T, it will not go to me. Just to warn you.
Good to know. I was going to say that a couple of people had said that they're not being able to. It's showing that it's under construction still. So
yeah. So just send a request to my email, and I will make sure to get it to you.
Okay. Okay, we got a bunch. Any opinions or experience with the TAP sleep appliance?
Yeah, I did talk about that. That's the anterior hook. I was trying to keep it neutral on brand names. I do not like it at all. I see bite changes, a lot of joint pain, not muscle pain, but joint pain. And so I kind of don't use it ever. And we just have better materials now and better systems of bringing the lower jaw forward.
Okay. Does the Epworth score need to be a minimum 11 to get approved for medical insurance?
Yeah, that's kind of in the weeds of what I could, do in this time period. But Epworth, I only fill out an Epworth because I think it's completely useless. It's basically a questionnaire, Lauren, that asks if you would fall asleep in certain situations. I don't think it's very indicative of sleep apnea. I don't think a lot of people underestimate how tired they are because they don't necessarily doze. But saying that, every sleep patient does have to fill it out because insurance requires it, and every patient is an 11 or more when we go over it with them. So yes, 11 or more shows a comorbidity of excessive daytime sleepiness.
Okay. This is a multi-part question, but this is actually pretty good. So for people who are using a CPAP, you had mentioned a lot of people don't know that they snore or that they have sleep apnea. If someone lives alone, for example, if they've been on a CPAP for a month or so, how would they know if it's really working? How do you monitor for that improvement? Is it helping the problem? And then when would it be time to think about an oral appliance?
So the CPAP is pretty much works if you wear it. So it just keeps blowing air indiscriminately, whether you can handle it or not, till the airway is open. It monitors you. It's like Big Brother. So it knows your usage. It knows if you have mask leaks. It knows what pressure, and it knows your AHI. That's all within the machine. So in order to be a compliant CPAP wearer, you have to wear it a minimum of 4 hours a night, 4 nights a week. And so I'm like, that is a lot of hours that they're sleeping with nothing. But that's being compliant. So they lowered the bar and they still can't meet it 60% of the time. So when it comes to CPAP wearers, there's some that love it and can't live without it. And I just like, good job. But There are some that use it all the time every night, but they only wear it till, the 4 hours and then take it off. And not because they want to, they just subconsciously do it. So there's a lot of times I discuss combination therapy or hybrid therapy, in which a patient will wear an appliance and a CPAP. So if they do take it off subconsciously, then at least they're doing something, even if it's not perfect because they're so severe, at least they're doing something the rest of the time they're sleeping. But I also use, especially if the patient's a bruxer, so it can work twofold as a night guard. But what it also does for CPAP wearers is it lowers the pressures. So the CPAP just blows air to blast open the airway. Well, it's going to keep blasting until it's open. So if most of the soft tissue can be moved away or opened with an appliance, then the CPAP doesn't have to blast as hard to keep the airway open. So essentially, the CPAP becomes a lot more comfortable for patients because it's usually high pressures that keeps them from wearing it.
Okay. What about for people that are on a CPAP? How do you deal with those sleep apnea patients who are claustrophobic and they just can't use it? Are you going to put them on an oral appliance more likely? Is it kind of the anything's better than nothing mentality?
Yep, and that's well most sleep physicians are, and that's how insurance is. And sometimes it defines what a trial is. Some have to go try the CPAP for 90 days before they can get an appliance if they're severe, but some it's 30 days. So yes, we can treat severe patients and do all the time if they're CPAP intolerant. But we also discuss maybe going back to the CPAP if it's high pressures that kept them away, so that we again discuss the combination therapy, and usually insurance covers both.
Now it's going to be sort of a related question. What if somebody travels a lot? Is there any downside to them taking an oral appliance with them when they travel and using that, but using the CPAP when they're home?
Absolutely not. There's times that, because I'll just ask patients that have a CPAP, they love it. I'm like, what do you do when you travel or go camping? Because we have a lot of outdoorsmen here. And if they say, well, I don't camp anymore, then I talk to them, or if they don't take it when they travel. So if someone loves their CPAP, I try not to take them off of it. But if they're not using it, then yes, it's perfect for travel. But you'll find a lot of mild to moderate patients weren't given another option and wear a CPAP.
Okay. Why are you not a fan of the EMA appliance?
The elastic stretch out, and I want a hard stop. I don't like that patients can retrude back, and those you're switching them out all the time. They don't have a 3-year warranty. The materials are getting better with EMA, so it's not a bad appliance. I just don't like the ability to stretch it out, and yeah, patients like joints. They like play with it all night.
Okay, I know we don't have it on screen. Can you just repeat what your email address is for people that want to reach out to you?
Yeah, it's on the screen. Or did you take away the screen?
Actually, no, it's still on Kurt's. We have the special up there. So I'll,
oh, okay.
Let me see.
I apologize. Maybe you could write it in the chat. Erin Elliott.
Oh my God, you're gonna make me work. Hold on. Oh my God, you're making me work here. This is crazy. Okay, hold on. So it is ERINELLIOTT.
DDS.
DDS@gmail.com. Done. Okay. Some more questions here. We got that one out of the way. If for someone that has maybe a CPAP and the oral device, will insurance typically only cover one of the two, or have you seen situations where you can get both covered?
Yes, most do. Medicare has something called the same similar, but yeah, most do.
Okay. What about, this is a good one too. What about patients who wear complete dentures? Are they candidates for this type of treatment, or what modifications do you need to make?
Can you repeat that? Sorry.
For people that have complete dentures, can they even wear an appliance, or like what would you do in those situations?
Yeah, so basically, in edentulous situations, I use a Somnomed. It's the best for partially or fully edentulous situations. So essentially, we replace the upper denture with the appliance. So it mimics the denture, but in size and shape, but it is an appliance. There's no teeth. And then the lower part will go over the lower denture or the lower teeth. You do have to have a good stable lower denture, however, so it just so happens that I place implants. So there's been a handful of times I do at least 2 implants to hold the lower denture in and then make an appliance.
Got it. What take-home sleep test do you use?
So our workhorse is a Medabite Junior, but there are some newer types. I love the WatchPat, but it is cost prohibitive. It's like $109. But again, my patients are paying cash, but Medabite Junior is about $6 to send out the door. And then Wesper is kind of like the newer technology. I don't like the rings because I think that positional data is very, very important. So I don't do any tests that don't have positional.
How do you deal with it when the insurance is going to be significantly less than the cover? Like someone had mentioned that they heard that the lab fee for Somnomed is like $1,500, and sometimes the coverage might only be $1,000 or so. So how do you make up for that difference?
The lab fee is only $600, but the way you just don't go in network with insurances that are ridiculous and then balance your cash fee.
That was another follow-up question. Are you billing medical insurance as an out-of-network provider? Is there like a credentialing process? And what about with Medicare? Are there certain restrictions from working with Medicare?
Yeah, there's absolutely credentialing you do. I stayed out of network for a long time so that we could balance bill and kind of control the narrative and get gap whenever we decided. However, most insurance companies, especially the major national carriers, have kind of come around and become reasonable. And so we're much more willing to go in network at that point. It does make things so much easier and streamlined, but I wasn't going to play ball with them until they were reasonable. So yes, we have recently gone more in network. Medicare, we are a non-participating provider, which means that the Medicare will pay 80% of their allowable. The supplemental usually covers 20%, and then we balance bill to our cash fee.
Good. Okay. What about, how are you dealing with like complex case like this? Someone had mentioned an example where 31-year-old, they won't wear a CPAP, they got large tonsils, many missing teeth. How are you going to even approach a complex case like that?
There's always a solution. Just know, I love that we dentists go to like worst case scenario when most of the patients are really pretty simple and straightforward. So if we get a complex case, you just problem solve. So really severe, not wearing their CPAP, you make them an appliance, and not a lot of teeth, you make them a Somnomed. Really try to simplify things. I don't think we need to overthink it too much. But every appliance I make is prescribed by a healthcare professional. So I am doing this alongside of someone.
Right. For the people that could benefit and that you recommend some type of palatal expansion, what percentage in your experience are actually going to go that route?
Not many. That's the problem. That's the problem when that's the only solution you give a patient. First, I think that the surgeries are the best way to go, not an appliance that's going to give you palatal expansion. So like a MARPE, SARPE, implant assisted palatal expansion in adults. Secondly, just because you expand the palate doesn't mean you're going to cure them. It's still a physiological issue. You still could have a collapsible airway. So giving them more room logically is going to improve tongue space and airway space and that sort of thing, but not a guarantee. So for patients to spend a whole bunch of money to expand, create spaces in their teeth, and then you have to somehow close the spaces with ortho or whatever is going to cost another however much. It just seems like we need to get an easy entry point for our patients. And that's why an oral appliance is just a simple, easy way to get them started feeling better. And then we can guide them down this path of trying to fix the problem if we can.
Yep, makes sense. Well, we're right up against the bottom of the hour. I wanted to obviously thank you, Erin. This was fantastic, really great information. Anything you'd like to say, some parting words before we call it a night?
My theme for 2025 is, if not us, who? And I think that it is imperative that we as dentists screen and talk to patients and help them live a longer, better quality life. So if you don't want to treat it, find someone who does, but start talking to patients.
Great advice. Well, thank you again. I think we should bring you back because we had a great turnout and this was great content. I know you only scratched the surface of some of this material. I wanted to thank Dr. Elliott for joining us this evening. Thanks to GoldenDent for sponsoring, for bringing her in. She's worked with GoldenDent for years. She's a client of GoldenDent. We love working with them and love that they are supporting continuing education in dentistry. We do these webinars on a regular basis. As Curtis said, the next one I think is June the 10th, and all of you who are here tonight will be sent an invitation for that. I'm going to send the list also to Dr. Elliott after the webinar because I believe she was going to send something to everyone, and that way if you didn't get a chance to write down her email address, that should be in there as well. Final reminder, the webinar is recorded. That should go out in a day or two. The CE can take up to a week, but maybe sometimes by Friday they can get it out. Keep an eye on that. There's nothing you need to do. When we log out, there's no registration or quiz or test or anything like that. It's all automated. So that should go out within the week or so. We thank you all for your time. We know your time is valuable. We continue to do these webinars on a regular basis, and we look forward to seeing all of you at our next webinar. Good night, everyone.